YouTube.
Yeah,
So viewers from YouTube will also join. Okay. A very good evening to one and all. I am Arpita from the IGCP group, the moderator for today's session. The topic that we are going to cover today is non-smoking COPD. So, non-smoking COPD refers to chronic obstructive pulmonary disease in individuals who have never smoked or have had minimal exposure to tobacco smoke. While smoking is the most common cause of COPD, non-smoking COPD occurs due to many other factors. So, in this session, it aims to shed light on the various causes, symptoms, and effective management strategies for this lesser known type of COPD. So, we have with us Dr. Prasanna Kumar Thomas, sir, to introduce us to this topic. And it's an honor for me to welcome sir and to introduce him to everyone. Sir has completed his MBBS and post that he has done diploma in tuberculosis and chest diseases. He has done MD in tuberculosis and respiratory disease medicine. He is a senior consultant pulmonologist at Sri Ramachandra Medical College and MGM Healthcare Hospitals, Chennai. So, with this very brief introduction of Sir, I would request him to please go ahead with the presentation. Over to you, sir.
thank you, madam, for that very kind, pleasant introduction. Thank you very much, and a warm good evening to one and all who's joined on to this webinar. I thank IGCP for having given us the opportunity to get together. We'll talk about the facet of COPD, which I think is so very important today, in the sense that this is almost overtaking smoking COPD in a country like India. We're talking about non-smoking COPD. COPD in people who have never smoked or who have stopped smoking or who continue to smoke. And that's really what this is all about. So we understand COPD is a vicious cycle of discomfort and dyspnea, which goes down, crashing down. This is very important. Once you make a diagnosis of COPD, you're going down the drain in the sense that you think that everything becomes more sedentary to avoid dyspnea, produce disease activity, deconditioning aggravates dyspnea, muscular dysfunction, then you have mucociliary dysfunction, structural changes, airway inflammation. There is a systemic component to this inflammation, which is so very important, which is the reason why COPD is a multi-component disease. The pathophysiology of COPD is multiple and systematic, and is very complex in the sense that there are so many of the comorbidities that we talk about in COPD today, which are present, especially comorbidities related to muscle mass, comorbidities related to the lung, comorbidities related to the heart, to cardiovascular system, to poor mental training and depression and things like that. So it's a multi-component disorder, and that's what we're looking at today. And it's increasing every day. Increasing global mortality of COPD is being seen. Major health problem. Prevalence underestimated as uniform diagnostic standards are not used. Well, the data, of course, is lacking. Today, of course, a working group, Indian guidelines were developed on the foundation of general recommendations. 65 million people have moderate to severe COPD, more than 3 million people died. The fact is that COPD is increasing by leaps and bounds. You take the whole complex of COPD, you have a different take altogether. You have non-smoking COPD, you have a different take on that. We just go through that in a couple of minutes. Prevalence of COPD was about 3.6 to 4.7%. It's probably a little more than that. COPD causes about 50,000, 500,000 deaths per year, causing a huge economic burden. And we understand that there's also not only a physical burden, but also a very massive economic burden on the exchequer. When we look at patients who are admitted with COPD, in the sense that the general feeling that we often have is that one COPD admission can treat a COPD for a year. That's the basic concept of trying to treat COPD. And I think that's where we are looking at as far as COPD is concerned. So I think it's important for us to realize that the consequences are not only physical, but also financial. So looking at the urban-rural divide and looking at the places where COPD, I'm sorry, 1 minute. Looking at the urban-rural divide and looking at the places, various places that are found in India, looking at a sample, I think it's sort of widespread across the board without question with urban and rural India. And you find that there is a general mix of urban and rural. And you'll find that odds ratio, confidence ratio with chronic bronchitis is about 95%. The burden of segregated respiratory diseases in India, COPD is about NS 211. Look at the GP, look at the specialist, whether it's a pharmacist, whether it's the emergency department, hospital, or whatever. Now, the FLAME was the study that really put COPD on the map in the sense that this was the drug which had indacaterol and glycopyrronium, and that's the one that really put set fire to this fire of COPD that you're seeing out in front of us. And we understand that the FLAME is an important study not only from the therapeutic point of view, but also from the fact that it heralds a milestone in the development of patients with COPD. And we understand that this is something that's going to have a profound impact on the way we look at COPD over a period of time. So, what did the FLAME tell you? The flame told you that there is a 16% risk reduction in moderate or severe COPD, and there's a 22% risk reduction in severe COPD in these patients. There's also a 19% reduction in mortality in patients with severe COPD, and I think that's what the flame has told us as far as we can see. So I think it is important for us to realize that there is a definite importance to this point that we're looking at. Look at the wisdom study, and you look at how you can withdraw ICS. In fact, today ICS steroid, ICS LABA is given more by default than by design. So I think it is important to understand that the wisdom showed that you can withdraw the ICS LABA and keep with the LABA LAMA that the flame proposed in these types of treatment. ICS are widely used in patients with COPD despite having little or no benefit. Corticosteroid resistance in patients with COPD. We understand that COPD is not very corticosteroid sensitive, but there are a subset of COPD patients who have more eosinophilic inflammation and who are significantly benefited by the addition of a small dose of steroids in these patients. So you look at the LABA LAMA and the ICS, we always understand that there's a clandestine understanding here today that if the LABA LAMA is the drug of choice today, the ICS fits in somewhere in the middle, either by design or by instinct, and I think it really comes into place. So the new classification of the etiotypes of COPD, for example, this you will find in the 2024 guidelines. You find that COPD is defined as COPD-G, COPD-D, COPD-C, which is the smoking COPD, cigarette smoking COPD. Then you have the biomass exposure COPD as COPD pollution P, and then you have other infections like bronchiectasis producing COPD, post TB COPD, which is called COPD-I, COPD enhancement, COPD enhancement. So they've started defining COPD as various causes and not only as smoking COPD alone. And I think that's the most important thing of what we are having at this point of time today. 60% of the Indian population lives in homes where biomass fuel continues to be used for cooking. Over 35 million people are engaged in dusty building and construction industry. And you find that the pollution burden is so high in people like India that crude estimates are that 60 million people suffer from COPD in India. And these are the various risk factors that you're looking at. You're looking at outdoor pollution. Of course, you're looking at smoking, which is an important entity. But I think looking at occupational exposure in patients with COPD and also looking at the biomass. Never forget this old lady who's cooking in a small hut without ventilation in the kitchen. She's using biomass fuel 24/7. Everything is done in that room, including living and washing and cleaning and sleeping and cooking. All these things are done in a single room with no ventilation whatsoever. These patients are prone for what is called biomass COPD or non-smoking COPD, as we'd like to talk them about today, or female COPD, and that's what we're looking at. So there are various other things that can cause COPD, like smoking, hookah, the BD, the chillum, the mosquito coils, occupational exposure, and chula. So there is a host of conditions that are associated with non-smoking COPD. Let us not get confused with the fact that it's only smoking COPD that you're looking at. And that's what we've been looking at for a long time. But we understand today that we have transformed from a classic smoking COPD into COPD of various causes that can look at in this. So you look at this today, COPD with asthma, COPD with rhinosinusitis, COPD with allergic rhinitis, COPD with other conditions, COPD with cardiac comorbid conditions for that matter, chronic congestive cardiac failure, looking at patients with coronary artery disease, looking at post tuberculous patients, patients with post TB emphysema, post TB fibrosis who are going in for COPD. These are the patients with non smoking COPD that we're looking at today. So, tobacco smoking is a major risk factor. Although in India, whether it's the BD, the hookah, exposure to biomass, fuel from vehicles, industrial units, household dust, and the rest, you look at the spirometry report, there is a very gross underdiagnosis about the use of spirometry in these patients. Why is there underdiagnosis of patients with COPD? The underdiagnosed patients with COPD revolves around the fact that COPD is, is diagnosed by spirometry, and spirometry is not a very common entity that's being used by a lot of people. So, poorly recognized underdiagnosis and underassessment of patients with COPD. Another very important factor at COPD is that it's got a very slow progression. We clearly need to understand that it's non-specific in its symptomatology to begin with. At least there's a little bit of breathlessness, little bit of cough and cold, which we pass off as due to age, for example, due to smoking, for example, due to pollution, for example. And then there is lack of statistical information. There's no real statistical data for us, and the pitfalls in the management have always been a problem in patients. Additionally, the ability to differentiate asthma from COPD, I think, is very important. We also understand that there is a definite entity which is called ACO, or the asthma COPD overlap. COPD are mostly under the care of primary physicians, doctors who practice alternative and traditional medicine, and the increasing awareness about the disease and use of spirometry among physicians has become an urgent need. So look at the economic burden. The economic burden is definitely going up. Even if you look at situations like from 1996 to 2016, there's a wonderful paper looking at economics and patients in India, for example, really going up by the core, which is a problem. COPD, is it a reality in India? And I think that's very important. COPD beyond smoking as a cause, smoking is by far recognized. Smoking behaviors in India are also peculiar, with a large number of people using non-conventional form of tobacco in the form of hookah, the BD, or the chillum. Traditionally, these forms of tobacco believed to be innocuous because of a variety of reasons, like passage of smoke through water in case of hookah. Lung cancer has been found to be nearly 6 times commoner in hookah smokers compared to non-smokers. The chillum is another very important entity here as far as the presence of COPD is concerned. So the burden of non-smoking COPD was about 45%. More than half the cases of COPD can be attributable to non-smoking causes. Look at Pune, look at South Africa, look at China, look at Wellington in New Zealand. Look at the USA nationwide. Of course, it's not as high as it is in India, for example, but still there is a percentage of non-smoking COPD factors. So, risk factors associated with COPD: treated pulmonary tuberculosis, we talked about that. Indoor air pollution, we talked about that as well. Occupational exposures, we've seen that. Poor socio-economic status and low educational levels. Look at outdoor air pollution and repeated lower respiratory tract infections in women. Please remember the old lady that we saw in the hut who was smoking. There was a small child at the back who was about 4 or 5 years, who's been standing there. And these are the people who are very vulnerable, not only vulnerable, but who are also exposed to this sort of fossil fuel smoke as such for long periods of time, over long areas of time that we're looking at. So the prevalence of chronic bronchitis in men and women, this of course is the typical post-TB COPD that I talked to you about, where you have destroyed lung with severe upper lobe destruction, severe emphysema, there's severe amount of air trapping, and bronchiectasis, and you find that COPD is a very classic phenotype in this sort of situation. So asthma is a risk factor for COPD. I think if you go to places like New Zealand and Australia, for example, where the incidence of asthma is very high, you'll find a lot of people going into this phenomenon of going in for echo and then finally landing up as COPD as such. In the sense that what started as an asthma where there was a reversal of obstruction, moves slowly and slowly and slowly, you find that the reversal keeps coming down. They finally land up with COPD, which is invariably irreversible. And that's what we are talking about as far as chronic asthma as a risk factor. Airways obstruction can lead directly to COPD. It is likely that a person with asthma, with or without additional risk factors, can predispose to a person. So, biomass fuel exposure in Indian scenario is very, very important. You look at more rural India, 90% of households. In urban India is about 32% of households. So, very large percentage of people in India using alternative methods, alternative modalities of cooking of biomass as such, and I think that's very important for us to realize. And we don't need to talk about air pollution, for example. Half of Delhi is polluted, half of India is polluted as well. Of all the South Asian countries, India is listed as the heaviest polluted country. 13 of the 20 polluted cities are from India, and I think this is WHO data. And we also understand the occupational exposure in these patients, brickfield workers, especially in places like West Bengal and otherwise, significantly lower lung function in brick workers as compared with controls, believed to be because of the dust that is inhaled and inhaled on a continuous basis. And you find that the FEV1 is grossly affected in these patients. For a long time, COPD has been thought to be a smoker's disease. Today, we understand that there is a lot more to tobacco smoke. There's a lot more to COPD than just tobacco smoke. We understand a lot of other things: exposure, pollution. We look at biomass. You look at comorbid conditions, look at tuberculosis, look at infections, look at bronchiectasis, look at a lot of things that can give rise to patients with COPD. Several studies found a large number of COPD patients who are non smokers. Indoor pollution, biomass fuel, I think, was a very, very important entity that we're looking at, even in developing countries and also in developed countries, especially in Southeast Asia, China, in Africa, in Southeast Asia, like Indonesia and Vietnam, for example. Very, very classic Thailand, Vietnam, very classic entities of biomass fuel being used for cooking. So, proportion of households using biomass, look at the percentage that we have in Australia, in Africa, and in Southeast Asia and China, I think. This is the major chunk where the non smoking COPD comes from. And I think it is very important for us to understand. Look at Java, for example. Java and Sumatra, I think it's important for us to realize that all these Southeast Asian countries have a high degree of biomass use in these patients. So, biological products with low combustion fuel efficiency leads to higher indoor concentration of harmful substances. Particulate size 10 to 2.5 micromu containing carbon monoxide and nitrogen dioxide gets deposited deep in the lung, generates a mean concentration of 300 to 3000 microgram per meter squared of ppm 10 in 24 hours, and 30,000 of ppm 3, for example, tested during cooking. WHO standards specify this to be 150 per meter squared in these patients in 24 hours. So, who are at higher risk? Obviously, the women are at higher risk. There is no doubt that women are the ones who are at more higher risk when you look at biomass fuel is concerned. Males are more at higher risk when you look at occupational pollution is concerned. And I think that's again very important. You put these two and two together, these are two big chunks of patients with COPD that you get, and I think it's important to realize. Babies born to mothers exposed to biomass smoke from open fires have birth weights 60 to 70% lower. So your COPD begins with mother who delivers a child. Mother who is exposed to biomass fuel delivers a child who's already underweight when he is born. And I think that's what is important. The baby is born underweight. And right from the beginning, I think there is a developmental abnormality that is there not only with the lung and the heart and the rest of the organs, but the whole system of development, I think, is retarded. And you find that they finally end up in patients with COPD. So, comparison of clinical features between non smokers of patients with COPD. Non smokers have less impairment of airflow limitation and gas exchange, lower prevalence of emphysema and chronic cough. Tobacco situation is warranted. Mexican women who had COPD been exposed to biomass fuel Mexico is very, very notorious for biomass as such, women with COPD exposure. And that's another area of South America where I think there's a huge deal of exposure as far as the biomass is concerned. Non smoking risk factors play a very important role, deterioration in lung function to that of smokers. In fact, in many situations, non smoking COPD produces a greater and greater rapider decline in lung function than in patients with COPD. Similar rise in inflammatory markers compared to those of COPD, whether you're looking at neutrophils, whether you're looking at CXCL8, or whether you're looking at MMP9, you find that all these biomarkers, as such, inflammatory markers, are definitely as elevated in patients with non smoking COPD as it is in patients with COPD. This is a very interesting difference that we get between smoking and non smoking COPD. More emphysema, more epithelial damage in patients with tobacco smoking COPD. More lung fibrosis, more pigment deposition, thicker pulmonary arterial intima in patients with biomass exposure. So you find with thicker pulmonary arterial intima, you find that the incidence of pulmonary hypertension, for that matter, is definitely more in these female patients who are exposed to biomass and who get COPD as a result of biomass as such compared to tobacco. There is a definite difference both in pathophysiology and also in the understanding of what we have as COPD as such. But I think it is very, very important for us to draw the verticals, not only as far as diagnosis is concerned, symptoms is concerned, but also as far as treatment is concerned, to sort of produce the right strategy for these patients as such. So, more emphysema in patients who have tobacco smoke and more airways involvement in patients who have biomass smoke as such. That's a basic entity. You look at these bronchiectatic changes that you're looking at in patients with biomass, where there's a definite more airways involvement. So COPD management in India, common challenge, lack of objective elements like spirometry, non-specific terms for asthma. GPs don't often differentiate between asthma and COPD. Inhalers and bronchodilators are commonly abused for non-specific cough and asthma is interpreted. Factors that play an important role in the development of COPD includes poor dietary habits, poor housing conditions, more exposure to occupational dust, and indoor air pollution. And I think difference in socioeconomic status does affect the treatment modality and the quality of life in a patient with asthma. So the underdiagnosis of asthma in India is very challenging in the sense that not only from lack of spirometry, not only from lack of awareness as far as disease is concerned, not only from lack of proper diagnostic facilities, not only from lack of the proper treatment facilities in the sort of non-specific way in which we use the inhalers and the bronchodilators for that matter. The specificity of COPD is not being treated as specific COPD by itself, but it's being treated as general airways obstructive syndrome, which I think is not the right way to treat COPD. And the curriculum of both the undergraduate and the graduation will need to be strengthened to empower doctors with knowledge required to manage COPD better. So there are significant gaps in primary healthcare. Lack of awareness tends to estimate. Primary care physicians are not aware, scarcity of human resources, disease remains inadequately managed since most of the primary healthcare units are not equipped with minimal instrumental facilities, substantial amount, even smoking cessation is rarely advised in routine medical prescriptions. So comorbid conditions of COPD, we've seen that already. CVD, coronary artery disease, you look at metabolic disease like diabetes, metabolic syndrome, obesity, syndrome X, you look at bone diseases like osteoporosis and osteopenia, the greater degree of stroke, lung cancer, cachexia for that matter, is a very classic phenotype that you see in patients with COPD. With skeletal muscle weakness, you have anemia, you have depression, you have cognitive decline, and all these things are very, very important when you look at these problems, psychiatric problems, gastrointestinal problems, cancer, cardiovascular, hypertension, diabetes, dyslipidemia, compliance rates to inhalers are lower in the rural population, and that's where the COPD generally comes from. The elderly male subset, when compared to their urban educated counterparts, compliance is directly proportional to the level of education and income. Lack of patient counseling leads to non-compliance. Patients who need counseling on smoking cessation, the medications, the correct dose, at what intervals the doses should be taken. So the myths about inhalers, regular use of inhalers is habit forming. Myth number one, oral therapy is better than inhalation therapy. Myth number two, inhalers are expensive. Myth number three, inhalers should be used only in case of severe asthma. Myth number four, patients often shy away from the notion of carrying and using inhalers in public. Very correct. Absolutely right. All these factors lead to decreased compliance of using inhalation therapy in patients with COPD. So the treatment options, of course, are the LABA/LAMA, which are the bronchodilators. Then we have the anti-inflammatory treatments in the form of the ICS/LABA, and also in the form of the inhaled corticosteroids, and also the oral corticosteroids for acute exacerbations of patients with COPD. Your preventive measures like smoking cessation, cessation of biomass exposure, cessation of occupational exposure wherever possible, trying to get them into a better occupation, and then trying to make the occupational pollution less. I think these are governmental and political instincts that needs to get treated over a period of time. Then of course you have non-pharmacological therapies like oxygen, for example, pulmonary rehabilitation, for example, looking at NIV, for example. And I think it's important for us to look at. So differences in treatment response in COPD, the use of ICS is associated with major controversies. Some studies demonstrated a significant effect of ICS in reducing the overall exacerbation rate in patients to moderate to severe COPD. In many studies, however, COPD has always been a problem, but today I think there is a definite shift in these patients. Today, with the advent of what we call triple drug therapy, with the LAMA, with the ULAVA, the LAMA, and the ICS, for example, I think it's made a huge difference in patients, the so-called triple drug therapy. The ICS LABA LAMA, especially the Ultra LABA and the Ultra LAMA, have made a huge difference in patients with COPD. So the concept of using ICS and inhaled corticosteroids in patients with COPD is being looked at under a different lens altogether at this point of time, especially because of the success that triple drug therapy has given us. So I think it is important for us to rethink our own ideas about the use of ICS in these patients and try and use triple drug therapy as much as possible in these patients. So level of inflammatory mediators are not significantly different between current smoking and ex-smoking. No pronounced anti-inflammatory effect. This is similar to previous research in smokers without COPD, and those who stop smoking. Lung inflammation is at least partially reversible, but it persists in patients with COPD after smoking cessation. So look at blood in the sputum, look at the other things, effects of triple drug therapy. We talked about triple drug therapy today. So it's very, very important to understand that triple drug therapy is the in thing to stay in patients with COPD. And these need to be treated continuously and treated carefully, where you try to keep the dose of the ICS as low as possible. By the use of the Ultra LABA and the Ultra LAMA, you find that the dose of the ICS can be kept down, and all the side effects of the ICS can be really dealt with as such in patients with COPD. And I think it's important for us to understand. The way forward is increasing the awareness of the disease in physicians and society, educate physicians on spirometry for accurate diagnosis, improvement in management of patients with counseling, smoking cessation, exercise, and pulmonary rehabilitation. I think there needs to be a different approach altogether to our vision of COPD. What is the vision of COPD that we have? Is it still this narrow minded vision of smoking COPD only, or you have broadened your vision to non smoking COPD to include the triple drug therapy for that matter in these patients with COPD? Because triple drug is really where we are going. Triple drug is the one that's going to be very effective over a period of time. And I think all of us need to realize that we need to take cognizance of this complex circle of diagnosis as far as COPD is concerned, and then try and move ahead as much as possible in these patients. So single inhaler triple therapy, look at the triology, for example, and finally the fourth ape for that matter, He's the sum of the first three diseases. He sees nobody, hears nobody, and speaks to nobody. I think we need to give up this three apes policy, and we all need to understand today that there are two definite types of COPD, though they are to a great extent. I think the fourth, of course, is busy with his mobile, as most of us are. We are doing more of the mobile and then of anything else. But ultimately, is it a dog or is it a wolf is really what we're looking at. You look at smoking COPD and non smoking COPD. The most important thing to realize about a relationship is that a great relationship is about two things. First, find out the similarities, find out the similarities. And second, respect the differences. Thank you very much for the patient listening, and a warm good evening to one and all. Thank you very much. If there are any questions, can we take them?
Yeah, sure, sir. First of all, thank you so much for the beautiful presentation. So now I would request all the audiences who are with us that if they have any questions, they may go ahead with that. Already, I have received a few questions that I would like to reach out.
Yeah.
So, first question, I think sir has already discussed. Still, the question has come: what are the diagnostic criteria for COPD in non-smokers, and how do they differ from those in smokers?
The diagnostic entity remains the same as such. There is no difference in the diagnostic entities. There is no difference in the cutoff of the FEV1s in patients with smoking and non smoking COPD. The only thing is, I think the approach to that is becoming slightly different, and I think we need to explore this approach a little more and try and differentiate patients with smoking and non smoking COPD. The first thing is pick up the non smoking COPD, and I think that's what is important. The pickup of the non smoking COPD is as important as the diagnosis and the completion of treatment as far as the COPD is concerned.
Right, sir. Moving on to the next query. What are the common comorbid conditions associated with COPD in non-smokers?
The commonest comorbidity that I can see is cardiovascular. Cardiovascular is one of the commonest comorbidities. The presence of pulmonary hypertension, for that matter, makes it very, very important that a lot of these patients, especially the non-tuberculous, the post-tuberculous patient, they go in for pulmonary hypertension very rapidly, and they have a cardiovascular problem that's sort of looming over them. So I think it's very, very important to realize the cardiovascular combinations are very common. The other thing that is common is the skeletal muscle dysfunction that they have, the asthenia and the skeletal muscle loss that they get in these patients with COPD. They're already terribly debilitated and lost a lot of muscle mass during the TB itself, and they get the COPD and lose further muscle mass. It becomes a little more difficult to treat these patients because they just the don't have the ability to manufacture the muscle strength which is essential in these patients. Even to expectorate, for that matter, you need a very clear level of muscular ability to expectorate as such, and even that is becoming compromised. So I think cardiovascular would be one of the main things. Then, of course, would be the asthenic COPD that I talked about. But of course, all differences are important. Yes.
Thank you, sir. Thank you so much. Another question is on prevention. What preventive measures can be taken to reduce the risk of COPD, in especially the non-smokers?
Preventive measures in non-smokers to try and cut down the biomass fuel as much as possible. Try and substitute it with cleaner fuels, and I think that's extremely important. Number one. Number two is that your local pollution, which is vehicular pollution, that again is a very important entity, especially in a place like Delhi, for example. Vehicular pollution is a very important entity. We need to try and look at that, look at further stages of that, and see what best we can do. Switch to alternative fuels, for example. The electricity as a fuel, I think, is a very important switch, and I think this is a switch that we need to consider very, very favorably. And also the fact that all these occupations and factories need to be modulated very carefully as far as pollution is concerned, especially these polluting factories. I think it's very, very important that we look at these entities, try and modulate them, try and keep them supervised so that they have certain stringent rules that they need to follow to try and keep the level of pollution down as much as possible. And for that matter, I have just forgotten to mention indoor air pollution. Indoor air pollution, again, is very important, which is caused by cosmetic things like floor mats and door mats and things like that. It's very, very important to look at indoor air pollution as well, and I think it's something that we need to look at. Yes,
Sir, would you like to comment on passive smoking? How does it affect? Because passive
definitely,
smokers,
passive smoking is very important. In Australia, for example, you cannot smoke at home. If your wife says don't smoke, you can be sent to jail.
oh,
So
wow,
that's the type of rules that they have, and I think that's what we need to do. We need to deal with this with an iron hand. The iron hand is missing here. There is
right,
this
right,
very
sir.
fragile hand that's being placed on you without any compulsion whatsoever, and I think we need to deal with this on a war footing as such. The smoking, especially, deal with it on a war footing. Look at air pollution. Today, it is becoming such a huge problem. Today, environmental pollution is becoming such a huge problem today that it's very, very important because it's affecting our climate, it's affecting our rainfall, it's affecting our temperature, it's affecting just everything around us. You have all these flash floods. Today we've had something in Wayanad and then in the Haryana. You will find it all over the place. There is no doubt at all about it because all this is man-made. It is made by you and made by me. And I think unless you and me become conscious of the fact that we need to confine ourselves to certain stringent rules that are very necessary, and these rules need to be implemented at all levels, not only by the government but also by the society as a whole.
Right, sir. Very true. Sir, would like to take the last question for today. Is there any role of genetic predisposition in the development of COPD among the
There is a
non-smokers?
definite role of genetic predisposition. There is no doubt about it at all. There is a genetic role of genetic disposition. There is also this question of the low birth weight, the non-smoking COPD child that gets born for these fossil fuel COPD and fossil fuel exposed women that I talked about. You find that the birth weight itself is less, and a low birth weight is one of the most important factors as far as adulthood COPD is concerned. So I think it's very, very important that there is a genetic link, though we've not really understood and captured the genetic link as such. There is a genetic link that we need to understand in these patients without question. But I think the question of transference and other type of occupational link is very important.
Right, sir. Just check. Let me check once. So, sir, these were all the questions for today. Thank you so much, sir, for taking
Thank
up the
you.
session, for giving us your valuable time and sharing all your knowledge with us. Thank you so much. I'm very sure all the audiences who have joined have been benefited by this. Thank you so much. Thank you,
Thank you,
sir.
Ma.
And
Thank you.
thanks to everyone for joining.
Thank you.
Thank you, sir.
Thank you.